I see my slide, sir.
Yes, we are.
Morning, everybody. The chairman and members, the paper I'm presenting is the prevalence clinical profile, correlates, and 6 months outcome of atrial fibrillation in chronic heart failure in Ibadan. It's part of the Ibadan Heart Failure Project. We know that AF is the most common sustained arrhythmia in clinical practice, and over 33 million people suffer from AF worldwide. According to the Global Burden of Disease Project, between the year 1990 and 2013, the rate of AF has increased by 50% in sub-Saharan Africa. It is a frequent comorbid condition in persons with heart failure. Heart failure begets AF, and AF also begets heart failure. Sometimes you don't know which is the chicken, you don't know which is the egg. Over half of heart failure patients and 40% of AF patients are hospitalized within 6 to 12 months. So both conditions are therefore strong drivers of healthcare costs in high-income countries, even in our own environment. It has been shown that the cost of heart failure patients with AF is higher than those in sinus rhythm. So presence of AF in heart failure is also associated with greater risk of stroke, longer stay in hospital, and more frequent heart failure admissions. And presence of AF, in a meta-analysis have been shown that compared to those in sinus rhythm, beta blockers do not even improve outcome in heart failure patients who are in AF. AF patients, therefore, are a peculiar group of heart failure population that needs to be studied. In addition, there are limited data on the characteristic clinical profile and outcome of heart failure patients with AF in sub-Saharan Africa in general and Nigeria in particular. So the objective of this study is to document the prevalence and clinical profile of AF in heart failure patients and their 6-month outcome. The study was conducted in UCH and is part of the Ibadan Heart Failure Project. It's a prospective single-center observational registry, real-time registry of all heart failure patients who are presented in the hospital, both acute and chronic, as well as inpatient and outpatient. It's a comprehensive database that will provide information to define the clinical profile, the characteristics of heart failure patients attending the hospital to assess the burden of comorbidities, such as atrial fibrillation, as well as define the short, medium, and long-term outcome of heart failure in the hospital. We'll also examine the psychosocial and economic burden of heart failure in that sick ethical approval was obtained and all the participants gave informed consent, and the study is in accordance with international guidelines. We enroll patients who met clinical and echocardiographic characteristics of heart failure. They were 18 years and above. We collected details of their clinical history, social demographic variables, their past medical history, medication, as well as 6 months outcome. We measure their body mass index. We also assess for anemia, as well as assess for presence of chronic kidney disease using the MDRD formula. ECG was obtained using the Contact Medical System machine. Atrial fibrillation was defined either as history of documented AF or presence of AF at the time of hospitalization on the 12-lead ECG. The absence of distinct P wave on the ECG and chaotic activity of the atria and irregular RR interval. Other ECG abnormalities were also obtained. Echo was done using a standard machine, and measurements were in accordance with the ASC criteria. These are the statistics that were employed, but just to mention that we did a Kaplan-Meier analysis to look at the survival information. So the mean age, as I said yesterday, if you remember, What we have here is about, sorry that I didn't put the value there, but 12% of the patients with chronic heart failure had AF, and the population we were studied was actually 580 patients. You can see here that the average AF patient is older than a normal heart failure patient who does not have AF, that is in sinus rhythm, and this is significantly different. If you look at their weight and height, the difference in the pulse, which is the patient who have AF actually had a lower pulse because many of them were on beta blockers and other things to control their rate. Apart from that, all the other variables were similar. If you look at in terms of the platelet count, we found that those in sinus had a better, higher platelet count, which is significant. Hyponatremia, sorry, that value is not correct. I'm sorry for that. Hypokalemia, the values were not correct actually, but what we noted that patients who have AF, they had a lower serum sodium, but because they are sicker and they were on higher doses of diuretics. Sorry for that. And then the creatinine levels were also higher in patients who have AF. Usually chronic kidney disease is a risk factor for development of AF. The other things we noted, the lipid profile, the fasting blood sugar were not significantly different. But if you look at the echo, it was obvious that patients who have AF have greater cardiac remodeling. They have a higher left atrium both index and AP diameter. LA-AO ratio was also higher. They have, those are the things we also noted in the study. And then the LA volume, RA volume, they were all higher in patients who had AF. We did a study of their survival. I'm just going to, because of time, just to show the survival curve. This is the mortality at 6 months. You can see that the mortality survival or probability of survival was higher in those who are in sinus rhythm compared to the AF people. Hospitalization also higher in AF. If you do all-cause outcome, both hospitalization and mortality, those in sinus rhythm appears to be better. So this, in terms of summary of the finding, AF patients in Ibadan, which I think may also play in many other parts of the country, are relatively older. Age is a known risk factor for the development of atrial fibrillation. They are older. They're slightly higher in men, but it's not really significant. They tend to have more cardiac remodeling. The LA diameter and volume appear to be higher, and they also have higher chambers in patients with AF compared to those who are in sinus rhythm. In terms of outcome, it appears that AF in our environment, even with this short follow-up, patients with AF appear to have a poorer outcome compared to those who are in sinus rhythm. What is telling us that we should see patients who have AF as patients who have a strong comorbidity that may lead to death or hospitalization, and such patients should be properly monitored and taken care of in the management of patients with heart failure. Thank you very much, sir. Thank you.
Yes, thank you, Dr. Aga. Victor, who is presenting next?
The next presenter is Dr. Iseko. Iseko, are you there?
Yes, I'm here, sir.
Can you share your slides, please? 10 minutes.
Okay, sir. Good afternoon, morning, sorry everyone. My name is Dr. Iseko. I'm presenting from Cardio Care Hospital in Abuja, and I'm going to be sharing a Nigerian experience from inside the cath lab of Cardio Care Abuja. So this is Cardio Care. We newly moved into this facility a few months ago from our old facility, and mainly the main reason with ICU, HGU, cardiac emergency room, cardiac biomarkers, and all of that. So I'm going to talk about a Nigerian experience of setting up a cath lab and some of the things we encountered and that may be helpful to the entire Nigerian Cardiac Society community. And I want to especially appreciate the Nigerian Cardiac Society for a very big role they played in assisting, in supporting, especially Dr. Oga, in helping in some of the educational approaches that Cardio Care has taken in the past. So our experience is multifaceted. I'll talk about the medicine and I'll also talk about the milieu and other things. The external factors that affected were mainly non-medical. As at the time we wanted to set up the cath lab, we got the cath lab into Nigeria since 2018. To get it cleared took several months. Northern Nigeria had one functional cath lab as of September 2019. By the time we installed it, it took another several months to also get it operational and to get different regulatory agencies in. So a lot of non-medical things had a role to play, and a higher threshold for commencement, skepticism from local providers by patients and doctors alike, and it was a relatively new area in northern Nigeria to go in. So I had to collaborate. We had to collaborate as a team with these people in the south in Lagos. Some other things that affected significantly are the fluctuating rates. The forex rate fluctuated severely from 200 to 500 at a time, down to 360 and up to 460. That significantly affected the cost of care, affected cost of procurement of materials and the supply chain. Interest rates not being publicly funded means that interest rates also affected significantly. Taxation and power provision were all significant things that have affected the Nigerian experience of a cath lab here in Abuja. We also had regulatory hurdles. The local regulatory bodies and the Nuclear Regulatory Agency had to certify that it was well protected radiation-wise, and practices and the SOPs were all in place. Development Regulatory Agency also had to play a role because the cath lab is on the first floor, because we had to put it close to the OR, which meant that we had to put structural alterations to the building to be able to hold the cath lab. The cath lab weighs about 1.5 tons. And so we had to create extra columns to support that. MTCN also provided CPD accreditation for Cardio Care and the Living Hospital Group to be able to give CPDs during our webinars. We have 3 generators to run it. We have our own transformer. We have multiple electrical equipment. So these are some of the hurdles that are non-medical that we had to, here's a waiting lounge where patient relative waits while the procedure is ongoing. So machinery. We opted for the newer flat panel detector cath lab, which reduces the amount of radiation in the cath lab. A single plane one, C-arm, the X-ray generators, and hemodynamic monitors are still on their way because of COVID, which stopped something from coming in. Intra-aortic balloon pump, and then a rapid in-lab POC testing for ACT, ABGs, PTINR for creatinine in case of emergencies when they are rushed in with an MI. These are some pictures from the cath lab, and you will see right there that is a programmer. This was during one of the CRT devices which we implanted. And then this is our control room. This is our cath lab manager who made a very excellent presentation for the allied health professionals of of multiple people in the cath lab, multiple specialties in the cath lab. So in terms of protection, we had to implement radiation control. The walls and the floor had to be lined. Of course, we had to break the wall to bring it up from downstairs with relative lead jackets and all of that. For the manpower, the Nigerian experience so far has been that we had to use multiple specialties and people to collaborate. 2 interventional cardiologists, 2 adult cardiologists, 2 pediatric cardiologists, endo, neuro, nephro, radiologists, because occasionally we have to do multi-modality imaging, look at the CT angio, and I'll talk about one of the cases that we had. We have one CTSU collaborating, radiation safety advice, and so many other people who are working in the cath lab to ensure that we provide service. So these are some of the things that we face. This is a moving image from one of the earlier studies we did, an emergency. This was one of the few cases we were able to get into the cath lab, not to balloon time, less than 90 minutes. All the others come in over 12, 16, 5 days, several days after having chest pain. And this was one of them, newly diagnosed diabetic 41-year-old. We are seeing increasingly, the case we did yesterday morning, a 42-year-old with not diabetic with triple vessel disease. So we are increasingly seeing younger age people with very severe disease are coming in for the first time. And this is from the cardiac devices done. This was a CRT device being implanted. The 2 leads have been implanted. The procedure normally takes about 4 to 6 hours. So it's quite long and extensive. And the main problem has been getting the coronary sinus. However, over time, we have improved and we have been able to successfully in the last 3 cases in implanting it without need for revision. So that has been quite a very sharp learning curve. Everybody plays a role in the implantation of the CRT. It's one that absolutely needs the nurse coordination from everybody, doctors, cardiologists, interventionists, everybody, and has been something. This is a picture of our HDU. Our ICU is still higher than this. All the monitors are invasive, so we can get the IABP, we can get the ETCO2, the CO2 monitors, SpO2s, and all of that. So immediately they come out of the cath lab, they get in here. They have ventilators in case they are having to have any ventilation. This is what our OR complex looks like. And so coming in straight off the bat, there's biometric lock that shows there. And then going forward, the entire flooring of the entire floor is done with antibacterial flooring, as you can see on the ground there. This is the OR changing room where all the lead jackets and the surgeons and the different people change before crossing the red line. And so that's the OR changing room. Now you will see that the red line is there, and the first door you are seeing on the left here is the cardiac OR, and the second door is the cath lab. And this was quite important from a flow perspective. We had to bring in some people from outside to come and look at the flow in terms of if you run into trouble in the cath lab, trying to move in. The cardiac OR has been delayed from being fully functional, and we hope that by February 2021, we should be able to start our open heart surgery program. This was significant delay because of the COVID situation, essentially. Now, all the doors are non-touch doors, fire protection, fire extinguishers, and all the water supply is also non-touch. The OR floor and the cath lab floor is also connected to some form of earth to give some negative charge, to give an antistatic charge so that bacteria cannot go from the ground upward. So the bacteria is stuck to the ground by the negative charging. If you enter the OR, as you can see, you will see the air vents at the top here. This is a laminar flow air system that makes sure that air cannot flow the other way up to the OR table. So like I told you, it's still being set up. So this laminar flow gives fresh air with the American standard of 7 to 14 air changes per hour. So that is with HEPA filters. That's what is shown here. Now, and this is the way the air goes out. Now, this is the connection to the socket to make sure that there's a negative charge on the floor for this. Now, from the medicine, about 57 cases, population about size about 57 cases, male to female ratio of 1.6 to 1. Coronary angio was the predominant service done, about 45 of these 57, accounting for 78.9%. Of these, 35.6% of the angios were positive. So about 1 in 3 had a positive angio at the time. And PCI was done. Of those people, 12 of them had PCI, but 4 had to be referred because of the heart surgical disease. And 12 were done successfully with no major complications. 11 devices were inserted, 3 successful CRTDs, and 5 ICDs. 3 of the 5 ICDs were converted from CRT. I will explain some of the cases. And permanent pacemaker, dual chamber pacemaker. One of the dual chamber pacemaker was converted from a CRT device that was initially planned. And the reason is that by the time the patient started reacting to lidocaine with very heavy hallucinations, he was a blind man with very heavy hallucinations. The shortest door to balloon time we've ever had was about 54 minutes. Patient was referred promptly from a tertiary teaching hospital. Diagnosis was made promptly. Patient came in and had money to pay immediately. So the problem has also been 2 minutes. Okay. Shortest pain time has been 8 hours. Otherwise, most patients come in days. The major complication we've had was active pulmonary edema. SpO2 dropped to about 50 something in a patient while we were doing CRT insertion. Procedure had to be stopped and condition was successfully treated. Then procedure was scheduled for a later time when it was completed. Other complications, hallucinations after lidocaine, the patient that stopped complaining, stopped cooperating, inability to cannulate the left coronary in one of the cases, who had an aortic aneurysm, a professor actually. The procedure had to be aborted. He had an aortic aneurysm and he tried to get it. It was quite difficult to achieve. One near miss that I must highlight for other centers is the fact that patient with elevated troponins, query NSTEMI, breathlessness, DM, and it turned out to be COVID. It's well documented that COVID raises troponin, so we had to, instead of putting everybody at risk, we had to refer to a treatment center, and you know, there were no real changes. We lost the patient to follow up, however, a senator. Methodology has been having to put in multiple checklists, and Atul Gawande, the best-selling academician who has published a lot, has been the guide in setting out several pre-procedural and post-procedural checklists. In terms of modeling, the Nigerian experience has been that we have to engage pre-cardio care training, and what has happened is that we've engaged in medical education. NCS has been quite helpful in this, and NCS supported this Abuja Cardiovascular Symposium. This was the 3rd Abuja Cardiovascular Symposium held last year in December with about 400 participants from about 19 states, where we taught how to read an ECG, how to identify MI, how to do BLS over 2 days. The pediatric symposium also talked about pediatric cardiology, and our pediatric cardiologist anchored that.
Dr. Seko.
Okay, thank you very much.
Conclude.
Okay, so out-of-pocket financing has been major, and these are the main problems and challenges of setting up a cath lab and running it in the Nigerian setting. Cardio Care is located in Abuja, and essentially is open to working with and collaborating in terms of research, giving feedback, and working with it. And this is peripheral angiography done in a patient.
Questions will come after the entire session is over.
Thank you, sir.
Thank you very much. We'll now call the next speaker, Dr. Florence Shaw. Are you there?
Yes, sir.
Can you share your slides, please? 10 minutes.
Thank you, sir.
Seko, please, can you unshare your slide, please, so that
Okay.
Florence Shaw can share?
No, sir.
Okay. Florence Shaw, you can share now.
Okay, sir.
The Vice President, welcome. Sani?
Morning, sir.
How now?
Fine, thank you, sir.
Well
You didn't hear my voice go.
Sunny, long time.
Yes, sir. See you.
Good morning.
Morning, sir.
Yeah.
Morning, everybody.
Francois, please share your slides and call the next speaker while you are trying to. So Guntade
Okay,
on. Dr. Guntade. Guntade, if Francois cannot share, we'll step you
Yes,
down.
sir.
Let Guntade start, then you can share.
I'm here, sir.
You can share your slides and start. We'll come back to Francois and Mankwe later on.
Uh,
10 minutes. Your time starts, please.
hello, sir.
We are seeing your slide. You can
Okay,
start.
sir. So I'll be presenting the topic, the title of the after is development and validation of the electrocardiographic diagnostic score of heart failure in patients with hypertension attending the tertiary hospital in Ibadan. So background, hypertension is the leading cause of heart failure in Nigeria, and the identification of low cost and simple bedside tests to aid the diagnosis of heart failure, especially in low research setting, has been an area of active investigation. Abnormal ECG patterns are particularly common in patients with heart failure and are predictors of morbidity and mortality, as was reported by Owusu and Zudi et al. Little is known about the unique ECG predictors of hypertensive heart failure in Africans and Nigerians in particular. Preventive health approach to reducing the scourge of heart failure will benefit from early detection of simple diagnostic predictors of heart failure in at-risk population using low-cost technologies like the ECG. The RISK-HHF study is a case control study that was designed as an initial step in the determination of the risk factors and diagnostic predictors of hypertensive heart failure. And the objectives were to characterize the ECG patterns in individuals with hypertensive heart failure compared to those with hypertension without heart failure. Develop and evaluate the performance of a regression model of ECG patterns that are diagnosed for heart failure in individuals with hypertension. The participants were recruited from the Cardiology 18 over a period of 8 months. We recruited 101 case control pairs who were age and sex matched. The study population were adults with a clinical diagnosis of hypertensive heart failure, who are the cases, and those without heart failure served as controls. The risk of heart failure was based on the modified Framingham criteria, and the patient was considered to have heart failure secondary to hypertension on the basis of self-reported history of hypertension and or the use of blood pressure lowering medication or documented blood pressure in the hypertensive range, as earlier reported by Olga et al. We exclude patients with heart failure of other etiologies, those with previous myocardial infarction or ischemic heart disease, COPD, pregnancy, and those who consumed excessive amounts of alcohol. All participants underwent clinical assessment, ECG, and echocardiography. And association between ECG variables and heart failure risk were tested with chi-square test. And following this, the data set was randomly split using the split command in Stata into a training data set and a test data set. A univariate model, univariate logistic regression modeling was then used to determine the ECG predictors of heart failure, and this was used to build a multivariate model using the training data set, and this was tested on the test data set. The HF diagnostic score was then developed using the multivariable regression model, using the beta coefficients of each of the predictors that were significant in that model. And this model was validated in another independent data set of individuals who are referred for electrocardiography in our laboratory. Goodness of fit and statistics of the model was tested in the training data set, in the test data set, and in the validation data set. And for all analysis, a two-sided p-value of less than 0.05 was considered statistically significant. So this is the baseline characteristics of the RISK-HHF study. And the mean age of both the case and control were comparable. They were in the about 60 years old, and they were about 49.5% of them were males. And those with heart failure were more likely to have lower educational status. and they were also more likely to have consumed alcohol before, and they also had a lower blood pressure and a lower systolic blood pressure and diastolic blood pressure, possibly because they were already on medications for heart failure at the time. Most of the ECG abnormalities were commoner in those with heart failure compared to those with hypertension without heart failure, from signs like cardiac to atrial fibrillation, mitral ventricular complexes, left atrial enlargement, left ventricular hypertrophy, and even KR isolation and QT interval, as shown in this table. This table 2 here shows the multivariable regression model of the HF sum diagnostic score, and only four of the ECG abnormalities eventually were independent predictors of heart failure in the multivariable model. Signs like cardiac was associated with a 7-fold increased risk of heart failure. Arrhythmias, which are defined as any of mitral ventricular complexes, atrial mitral complex, or atrial fibrillation, and conduction abnormalities, which are defined as anybody with AV conduction, AV block, or left bundle branch block, or fascicular block. This was expected with about 3-fold increase of heart failure, and those LVH also had about 4-fold increase of heart failure. These are the beta coefficients of each of the predictors, and these were summed together to give a total score of 6. So anybody who had signs like that was given a score of 2, arrhythmias was given a score of 2, conduction abnormality was given a score of 1, and LVH also was given a score of 1, making that score of 6. Now, using the ROCTAP command in Stata, this table shows the diagnostic accuracy of this score at different probability of heart failure. And as we see here, the sum diagnostic score had an accuracy of about 75% in those with intermediate probability of heart failure, those with probability of between 40 and 60%. This is the receiver operating characteristic curve of the sum diagnostic score in the training data sets. And we can see here that the area under the curve is 0.8, which suggests that the score has good accuracy. And the goodness of fit is also good. The figure 2 here shows the performance of the score again in the test data set of 50 participants. And here again, the score performance was also good with a statistic of 0.73. So the score was then validated tested in the validation cohorts of those who are referred for electrocardiography based on different indications. And this is the clinical characteristic of those patients. The mean age was about 68 years. And the males in this cohort, about 42% of them were males. About 3/4 of them had below tertiary education. And as we see in table 5, in these people also, about 16% of them had signs like cardiac, about 6% of them had atrial fibrillation. Any arrhythmia was seen about 18% of them, and conduction abnormality, left atrial enlargement, left axis deviation, left atrial enlargement accounted for most of the abnormalities in these people who are referred, either because of hypertension or heart failure or any other indication. And the sum diagnosis score in these people was also excellent. The statistics was 0.79, meaning that it captured up to about 80% of people in this study, in these cohorts. And using the ROCTAP command again, we see that the score also similar accuracy of 74% in these validation cohorts. Figure 4 here shows the performance of the score in the general population, in this whole population of this HHF study. And as we'll see, individuals with a score of 0 or 1, a score of 0 or 1 does not really contribute much to diagnosis of heart failure. Whereas those with a score of 4 have almost 100% probability of having heart failure, with a score of 5 or 6 in virtually diagnostic of heart failure in these people in the risk HHF. So what do we make out of this study? High prevalence of ECG abnormalities is common in hypertensive with heart failure. Whether these ECG abnormalities are a result of progressive myocardial dysfunction position of decision in electromechanical activation, or conduction in heart failure, or both, are difficult to determine. ECG abnormalities develop early in the progression of heart failure, and abnormalities of electrical coupling are having gas of dangerous ventricular rhythms, which are associated with worse prognosis in heart failure. Thus, early detection of these rhythm malfunction abnormalities can identify patients at increased risk. The ECG is a particularly attractive, cheap, and easily available test that may be used in the stratification of patients who may need specialist care, especially in the community and also in primary care. Heart failure remains an enigmatic diagnosis in low-resource settings where access to cardiology services may be limited.
2 minutes,
And a
please.
simple diagnostic score of heart failure
2
in the
minutes.
stratification of population. Yes, sir. The ECG score has value in those with diagnosis in primary care, and this is important in stratification of patients with specialist referral, commencement of appropriate therapy. So in conclusion, this score consisting of sinus tachycardia, arrhythmia, and conscious abnormality, and LVH has value in heart failure diagnosis, and this has clinical importance in stratification of patients with hypertension. Regular ECG should be done in patients who are on treatment for hypertension to identify early these markers of heart failure. This will aid detection and secondary prevention. There's a need to validate this score again in the larger population of hypertension patients. Thank you for listening.
Yes, thank you, Dr. Gunchade. So is Dr. Folorunsho ready with his presentation?
Yes, I'm ready, sir.
Okay, you can share your slide.
Good morning, panelists. I want to appreciate once again the president of our association and the local organizing committee for giving me the privilege to present. I'm presenting a case of pheochromocytoma managed in our center, Federal Medical Center of Ondo State. Pheochromocytoma is a very rare tumor of sympathetic nervous system. It is one of the endocrine causes of hypertension. Endocrine causes of hypertension account for less than 5% of all cases of hypertension. And out of this, pheochromocytoma account for less than 1 in 1,000 cases. The objective of presenting this case is to emphasize the need for high index of suspicion for rare condition and possibility of cure in patients with secondary hypertension like pheochromocytoma. The case report is a case of 26-year-old lady, hypertensive, referred to a facility from a nearby University Health Center at Ngba. She presented with 13-year history of recurring headache, excessive sweating, tremor, and palpitation. She has had 3 episodes of hypertensive crisis prior to presentation. She had positive family history of hypertension in both parents and her elder sister. Prior to presentation, she has been on several antihypertensive, amlodipine, diuretics, propranolol, but at the time of presentation, she was on atenolol, amlodipine with poor BP control. On examination, we find a young lady, conscious but restless, sweaty and dehydrated, not pale, aneteric, no cyanose, no hysteresis, and no pedal edema. The heart rate of 106 beats per minute. Blood pressure were elevated, 160 beats over 110 on sitting, 150 over 100 standing. JVP was not elevated. Heart sound were S1 and 2 only. Other systems were essentially normal. We made an assessment of severe hypertension with the suspicion of secondary hypertension because looking at the age and the history of symptoms that I have been experiencing this since 13 years, most likely a secondary hypertension, and we suspect pheochromocytoma. The patient was admitted at the emergency unit stabilized within 48 hours. And the blood pressure was controlled with atenolol and prazosin. The initial investigation was, as highlighted above, blood sugar, normal, 2-hour postprandial, 6.9 normal. The total cholesterol, the LDL and HDL were within normal range. And the triglyceride was low. There was hypochloremia and hypocalcemia. Other electrolytes were within normal limits, and urinalysis was normal. The full blood count with differential review, PCV normal 39%, and there was relative lymphocytosis of 68%. Other blood cells were within normal range. ECG review heart rate of 100 beats per minute in sinus reading and normal axis. Echocardiography done for this patient was entirely normal. We actually do not have this facility in our center, but we have to send it to another lab at Lagos, where the diagnosis was confirmed with the elevated 24-hour urinary non-epinephrine, dopamine, and catecholamine, as highlighted on the slide. The 24-hour epinephrine excretion was within normal range, but that of non-epinephrine, dopamine, and their ratio with creatinine were markedly elevated. Also, the catecholamine metabolites, that of the metanephrine and the metanephrine were within normal range, but the non-metanephrine and the ratio were markedly elevated. Another investigation that we did for the patient include abdominal ultrasound, which revealed every other thing was normal, but the right adrenal gland was markedly enlarged with a homogeneous ecotexture, which measures 6.3 by 4.16 centimeter. The abdominal CT equally revealed normal, other structure were normal except the right adrenal, which was heterodense in structure with a single small calcification seen in the upper lobe of the mass, and there were evidence of some hyperdense zone cyst. Also, MRI was done in another, because we do not have MRI in our center, it was done somewhere else, which also confirmed the same reveal well-defined soft tissue signal intensity with right suprarenal mass lesion showing multiple cystic area. The left adrenal gland showed normal morphology and signal intensity. No other significant abnormality detected. This patient had a successful surgery of the resection of the right adrenal gland after the patient was stabilized 6 weeks after presentation, and the BP control, and when we also ensure we have achieved good BP control of 110/70. The mass was sent to histopathology lab, which result came out to reveal a nodular mass that with measure of 5 by 5 by 4 centimeter. The cross section was well circumscribed with area of hemorrhage. Second show normal adrenal cortex along the tumor. The tumor comprises of nest of cell with vesicular nucleus and vacuolated eosinophilic cytoplasm.
Just 2 minutes, 2 minutes.
And with a final diagnosis from the histopathology lab, confirmed a pheochromocytoma benign. And on following up, the patient was also able to do methanephrin and VMA, which were within normal limits. Patient on follow-up was weaned from antihypertensive over 3 months, discharged from the clinic after 1 year of follow-up, and has been normotensive for the past 8 years on phone call for follow-up. Conclusion, we want to emphasize here that all these rare conditions with high index of suspicion, we might be able to identify them. Unrelenting effort at diagnosis through adequate investigation, prompt intervention are indispensable tools in successful managing patients with pheochromocytoma or any other secondary cause of hypertension. This will not only take care of the hypertension, which could be otherwise fatal. It also removes the economic burden from the cost of antihypertensive drugs and improve the patient quality of life and reduce patient load in an ever busy hypertension clinic. These are my reference. Thank you for listening.
Thank you so much, Dr. Florenshaw.
Thank you, sir.
The next presenter is Dr. Nemalokwe. Relationship between plasma homocysteine and blood pressure in hypertensive northern Nigerians. Dr. Nemalokwe, please. Okay, is Dr. Nemalokwe around?
I think she's not there. She has not been appearing for the presentation. So let's take another
the next speaker. We go back to Dr. Shibowale again. Longitudinal
sorry, sir.
Okay.
Prof, can we take those who could not share, like Dr. Mankwe?
Okay.
Dr. Mankwe could not share. It's like, if it's ready now, we can take him before we go to... Dr. Mankwe, are you ready now? Is he still there? What if he's not there? You can call on another person.
Yes, sir. So we go back to Dr. Shibowale. Are you ready?
Yes, sir, I'm here. I'm ready, sir.
Right. You can share your slides, man.
Okay.
Six.
Good morning once again. I'll be talking about longitudinal strain bullseye plot pattern in 3 patients with suspected cardiac amyloidosis at University College Hospital, Ibadan. My name is Dr. Bamikole Oshibowale. These are the authors. No conflict of interest. Cardiac amyloidosis is an infiltrative cardiomyopathy characterized by deposition of amyloid fibril in the extracellular space of the heart and a potent poor prognosis. Up to about 30 precursor proteins that can actually misfold because they have unstable tertiary structure have been identified. Now, transthyretin amyloidosis and amyloidosis involving the light chain, which is actually from B cells dyscrasia, are responsible for more than 95% of cardiac amyloidosis. The diagnosis is actually quite difficult. It depends on clinical suspicion and combination of imaging modalities and endomyocardial fibrosis. The definitive diagnosis by myocardial fibrosis is actually not routinely done because of sampling error and risk associated with the procedure. Echocardiography is a non-invasive imaging modality used for initial assessment of the patient. It is usually difficult to differentiate cardiac amyloidosis from other causes of left ventricular hypertrophy that are more prevalent, such as hypertensive heart disease, hypertrophic cardiomyopathy, and is a relatively new and user-friendly modality. Can help. Now, the bull's-eye plot demonstrates its amyloidosis and provides additional diagnostic value. For it,
So,
Network.
I think Dr. Shibawala is having
maybe.
problems with his network.
Dr. Shibawala, are you still there? The network. Yeah.
oh, okay, I'm back now, sir.
Okay.
Okay.
You can share your slides again.
Maybe his network is not stable.
Yes, I'm back, sir. All right, so the three cases that we have, the first case, a 82-year-old hypertensive with 8 months history of exertional dyspnea and bilateral pedal swelling, with other features that were suggestive of heart failure. ECG showed low voltage complexes. The 2D echo showed left ventricular hypertrophy with granular speckled appearance, impaired by ventricular systolic function, restrictive diastolic dysfunction, and by atrial alignment and mild pericardial effusion. The global longitudinal strain average score was minus 6.5%. The second case was of 60-year-old hypertensive blood pressure was 140 over 100 complexes, and then the global longitudinal strain score was also low at minus 3.7%. The third case is a 60-year-old man with history of exertional dyspnea and bilateral pedal swelling of 4 months duration, had other findings that were suggestive of heart failure.
Your office on the right.
The ECG were not what's relative to the left ventricular hypertrophy that was identified in the patient will actually be regarded as low voltage complexes. These are the ECGs. This is ECG of the first patient that actually showed low complex voltages, and also this is for the second patient, the same low complex low voltage complexes. The third patient will actually not meet what we'll describe as low voltage complexes for the limb leads and the chest lead. But if we compare with the left ventricular hypertrophy, we'll actually still regard it as low. This is actually the the epical 4-chamber view of what the images are not really very. There's left ventricular hypertrophy, and then the first and the second patient had this granular sparkling pattern, was more in the septal area for the third patient, and then we could see some pericardial effusion for the second patient. Now, automated functional imaging was performed.
Thank you. If you're having questions, let me stay in
images using transthoracic echocardiography for the patient in the following order. First, in the apical long axis, 4-chamber, 2-chamber view. And then we had a bullseye plot generated automatically using the EchoPark Healthcare from GE with its S7. This is actually the strain curve for the first patient that I talked about. Here I show us the video of the views that were obtained for the patient. The 4 apical view, and the 2 apical view, and then also the 3 apical view. And then we could see the automatically generated bullseye plots in the other part. Now, this is actually the result of the bullseye pattern. If we look at the images as shown, there appear to be some areas of sparing in the apical segment of the bullseye plot compared to other segments of the left ventricle. Was clearly demonstrated in the first and also the third. The second one actually shows some tilting towards the septal area. So in the bullseye plot, the red part actually showed area of good strain pattern, while the blue part actually show an area of significantly reduced systolic function. Now, amyloidosis are a group of disorders that are characterized by deposition of extracellular proteinaceous material called amyloid. The amyloid deposit results from abnormally functioning plasma cell mutation of the transthyretin protein, which can either be hereditary, the mutation of the transthyretin, which is hereditary, and also there's a wild type that is used to be described as this senile systemic amyloidosis, usually found in people that are aged 60 years and above. The deposit leads to a loss of normal tissue anatomy and function. Now, the diagnosis is often difficult, as I talked about. Echocardiography is the initial screening imaging modality, but features are non-specific. The 2D speckle tracking image has been shown in previous studies to be sensitive and specific in the diagnosis of cardiac amyloidosis. Sensitivity put at 93% and specificity put at 82%. The global longitudinal score average for the patient were abnormal, and the high plot demonstrated the typical relative apical sparing pattern that's been noted in previous studies. This pattern is not found in other cardiac infiltrative diseases. Cardiac magnetic resonance imaging also have additional diagnostic value with late gadolinium enhancement, but is often not readily available even in our own environment. The endomyocardial biopsy is not routinely done in our environment and has low yield and high procedural risk, though current guideline recommends it for confirmation of diagnosis. Now, in conclusion, the longitudinal strain bullseye plot is an additional non-invasive screening tool for patients with suspected cardiac amyloidosis. This is of high diagnostic value in our environment where logistics for further diagnostic procedures may not be readily available. It's quite possible that in the future, this longitudinal strain bullseye actually may be incorporated in the diagnostic tool and algorithm for evaluation of patients with cardiac amyloidosis. Thank you. These are some of my references. Thank you very much.
Okay, Professor Gambalti.
Yeah.
You can introduce the last speaker.
I'm not sure the list is within me here.
Okay, the list.
If you don't mind, can I present my last paper so I can concentrate on the AGM?
Okay, President,
Okay.
you can go on.
Fine, you can go ahead.
President, you can share your slides and start.
Yes, sir, I'm sharing. Good morning, everyone. Sorry that I had to move the clock so that I can concentrate and get for the AGM. The last paper I'm presenting is the Ibadan Heart Failure Project, or the Ibadan HF Project, the rationale and design. We know that until recently, it was known about the emerging problem of non-communicable forms of heart failure, supplementing the traditional pathway to the syndrome of or the syndrome in sub-Saharan Africa due to infections and infestations. So contemporary studies from South Africa, Nigeria, and other parts of Africa, sorry, it's moving too much, have built on the historical reports to demonstrate that the etiology and indeed the case profile acute heart failure, which more in women and younger individuals affected in the prime of their life, is different from high-income countries. As such, heart failure is now responsible for 7 to 10% of medical admission in the region. These are entirely based on studies on acute heart failure, there is practically few or little data on chronic heart failure in the continent, and then the relationship between common infections and heart failure have been less studied. So these are some gaps. And if some of us are reading literature, we'll find out that issue of multimorbidity and comorbidity is an issue in heart failure research now. So comorbidities including heart failure, which are common and important to outcome, have not been well studied, just like we presented the paper on atrial fibrillation this morning. The role of occurrence of infections such as tuberculosis and HIV also has received little attention. And then we don't really have quite long-term data, probably 6 months, 1 month, 3 months, and 1 year data, what is happening we have. The current phenotypes of heart failure using big data has not also been properly explored in our own country, except the Texas data. Some issues are coming out from there. There's also the issue of barriers to management of chronic heart failure. Significant, given the potential enormous cost implication, we have little information on cause, and catastrophic cost has not been explored, and all those cost effectiveness in the management of different aspects of heart failure has not also been employed. We also know there are few genomic studies. We do not know what the extent of standard care pathways and evidence-based treatment algorithm applied in the management of chronic heart failure in the country. And we do not know to what extent high out-of-pocket expenses contribute to low level of treatment. Furthermore, we do not know the scope of quality improvement to improve outcomes to reduce mortality rates in Nigeria. Although there is existing evidence of economic costs and impact from abdominal heart failure, data on catastrophic costs is not known. In addition, patient-centered approaches has not been really explored. So the primary objective of this is to assess the long-term outcome, risk for clinical phenotype, genomics of chronic heart failure, an estimate of catastrophic costs associated with heart failure, and how it affects evidence-based care. That is what we explore. And this shows the extent of objective this long-term project we try to explore. Because of time, I'm not going to go through them one by one. In terms of the study design, it's a prospective study. It's at a burden. All patients will be included. It's only those who do not give consent. We have well-defined case definition and data on socio-economic, clinical profile investigations will be done. Case definition will be based on ESC criteria and blood collections. Some that we have capacity to do, and those we do not have capacity, we are storing biobanking in order to explore some of this in future. Follow-up will be done using clinic follow-up or follow-up telephone phone call. The outcomes are used is basically on rehospitalization, mortality, or all-cause outcome. Assessment of barriers will be done. We also capture dietary question and also community engagement. Here, an anthropologist is planned to be part of this project, and a health educationist as well. In addition, we also capturing the issue of training, such that we invite people who are interested in the MED or MD or PhD programs of Department of Medicine in Ibadan from anywhere in the country who want to use the data that we have to do their program, as well as work with economists to get economic analysis properly done. This is the sample size calculation. Initially, when we submitted this for an international funding. We intentionally wanted to do 800 patients, but they said, no, that's not enough. We need to capture more patients, not because of the questions we want to answer, especially when you want to do genetic studies. You need in thousands, 2,000 or 3,000 patients. So statistics is what is there, and the ethical considerations have been well captured in the project protocol. And then expected outcomes, expect at least 10 original publications, capacity building and training, PhD, MED, MD program, community engagement, which is community education on the impact of heart failure and their understanding of heart failure, and then improvement of community knowledge, and then the issue of career development for those who will participate and who will be trained through the project. Progress so far. So far in the chronic arm, we have 988 subjects, and about 94% of them have ECG. 85 have echo, the full blood count 76%. So this is a real life study. This is what happens. We don't push patients if they don't have money to do that. But ENU, 91%, 95% have completed 6 months, 87, 12 months, and then 18 months, 79%, and then 71% have completed 24 months follow-up. And our aim is to get as much follow-up in the data as much as possible to reach 100% or at least that's our aim, to get 100% follow-up. For the acute arm, which has actually suffered a lot of injury from COVID, because the people, our research assistants who have been helping us, we don't want them to go to the ward at the time now. So since March, we have actually not captured the acute heart failure, but we have 620 patients there. And you can see that completeness in the follow-up, which we're also driving to get as much as possible. So in terms of summary, what does this chart just so summarizes what we're doing, want to do. The most important thing is heart failure care program. We want to start a lot of programs through the project. And then heart failure-based research, outcome study, economic of biomarker genomics, nutritional related study, comorbidities, psychosocial problem, population screening program, prevention. So I want to thank those who have participated, especially our research assistants who are working with us. And then these are my references. Thank you very much. Professor, I'm done, sir.
Okay, thank you very much, President, for keeping to time. You ask questions at the end of the, please, you can post your question to the Q&A section. We'll take them at the end of the last presenter's presentation. Please don't share your slide, President. We'll now call on Dr. Adamu. Adamu is, I think, are you in Nigeria?
I'm not in Nigeria.
That's a good thing about
no.
You're in South Africa?
Yeah.
It's good.
Share your slide.
Okay.
At least Professor he will enter your report. They will have international presentation.
Very serious.
Okay, great. Okay, great. This one.
Yes, 33 is your number. Click.
Okay, okay.
Slideshow.
Okay. Okay, let's go.
All right, your time starts now.
Okay, thank you so much.
Yeah, okay.
Can you see my slides?
Yeah, very good, very well.
Okay, good morning, Mr. Chairman and other members of the panel. I will be presenting management of luminal loss during cardiovascular intervention in a patient we saw here in Johannesburg. I'm presently a cardiology fellow with Charlotte Makeke of the Wits University. I have no potential conflicts of interest. And he's a 6-7-year-old man that we saw and was investigated as an intermediate risk and STEMI. He came in with his STEMI was 2 and the CLIP was 1 and a grade score of 126. That makes an intermediate risk score. And had an acute onset of chest pain for about 2 hours. There was no shortness of breath. Apart from age and being a male, he had no other risk factors. And the past medical history was nil of note. The investigations done included the ECG that showed a sinus rhythm and F-segment depression that was noted only in 2-3 and AVF. On echo, he had a good AF of 52% and no regional wall motion abnormalities were seen and no significant valvular abnormalities. Of course, he was started immediately on aspirin and then had a loading dose and 75 milligrams later. He was also given clopidogrel, a 600 milligram loading dose, and had a Clexane, an atenolol, and sublingual nitrate, as well as atorvastatin. Reminding you that in the latest NC guideline concerning the management of patient with NSTEMI, can you hear me? Hello, someone?
Yes,
can you hear me?
Yes,
okay.
I can hear you.
Okay. That if you don't know the anatomy, you don't give a loading dose of clopidogrel. The troponin done initially was 17, and a repeat later was 160. In my own center, we rule in acute coronary syndrome when it's more than 100. And the lipogram was essentially normal, and he's not diabetes. Kidney function was also normal. And this is the angiogram. I'm trying to play it. Yeah. Wow. It's not playing. Yes, sir. Man, it's not playing. Wow. We're just trying to play the angiogram, please.
What is codec? Codec is not available. Maybe there's something else to do.
Wow, let's try to play the angiogram, please. Let's go to the next slide already.
Why not move on and just tell us what the angiogram shows?
Yeah, the angiogram is not playing here. That's it.
Just discuss it.
Yeah, discuss what it shows.
Okay, so what we did was, of course, we usually start with the diagnosis. He was not taken to cath lab immediately because it's intermediate risk. And so what we did was we took him to cath lab the following day, and we went to radial anyway. That's standard here. And then after the diagnostic, it found that he had the left coronary systems were essentially normal, and the problem was on the right side. And he had 2 critical lesions, one in the mid segment and the second one in the distal segment. And the distal one was actually a bifurcation lesion, Medina 011. And then it's a pity that it's not showing. And so we actually decided to go in to intervene in him, and we needed a good backup. So we used AL1 guiding catheter, and we went in with a BH with heavyweight guiding wire, and we ballooned the lesion. Of course, there are 2 lesions. We ballooned the first lesion, the distal lesion, with 2.75 by 20 mm NC balloon, and then the middle lesion. Immediately, we lost the lumen. Okay, and of course, we still had our guiding wire in, but what we did was to bring out the balloon. Of course, when you dilate, you have to just inject contrast and see if actually you've actually been able to open the vessel, and that's when we knew that we've lost our lumen. So we brought out the balloon and left the wire in, and we tried to see whether what we had was a dissection, or it was a vasospasm, or it was a thrombus of trash further down. And you can see here that the patient was at that time unstable. You see that he has a segment elevation. He was also having chest pain. And so what we did now at that stage, there are so many things you can do to know. But what we did actually was to use that same balloon and we cut it in longitudinally and then put it in, and we injected medication distally to see whether it is a dissection or a vasospasm. If it's a dissection, we may not be able to get anything down, but because it was just a spasms, we're able to get a flow distally. And then with that, we delivered TNT, we gave him Agrostat, we gave adrenaline, we also gave Verapamil as well as Agrostat, a loading dose. And then we use another balloon to then dilate the lesion. Of course, the lesion is dilated, and then we now went in with two other stents. Two stents. First, the distal part, we use Biomine 2.75 by 24 drug-eluting balloon, a blood-eluting stent, which gave good result. And in the mid segment, we use Resolute Onions 3.0 by 26 drug-eluting stent, and he was well. It's a pity that it's not showing, but you can see here that after this last balloon was deployed, the last stent was deployed, his segments elevation that were thin, normalized, and the patient was stable. Here, that percutaneous flow intervention may be associated with adverse procedural and clinical outcomes. No reflow phenomenon is common and can be up to 60% in some individuals, most likely due to either dissection, atherothrombotic embolization, or not. Just like I said, you also have to try and define what you're dealing with, either it's a dissection or not. And for us to say you have a no reflow phenomenon, it means that you're unable to restore optimal intramyocardial perfusion despite opening up the epicardial coronary artery. That is, the TIMI flow or the myocardial blush is less than 1. And the causes, just like I said, either you have an ischemic injury and or endothelial injury. Of course, with endothelial injury, when you try to perfuse again by ballooning, you worsen the injury because you're going to reperfuse that system and then you worsen it. It can also be due to microvascular atrial spasm and trashing of the thrombus. In our own case, we couldn't see any thrombus because we actually aspirated. We use microcatheter to aspirate. We use catheters to aspirate. We couldn't get anything. And of course, you know that no reflow phenomenon is associated with increase in intra-hospital mortality, malignant arrhythmias, and cardiac failure. Of course, what we did was we remained calm, just like I said. We maintained wire position, and then we assessed for the hemodynamic and clinical stability of the patient. And those medications I mentioned were delivered: adenosine, nitrosin, adrenaline, Agrostat, and they were aspirated as well. Just like I said, there was no thrombus. And in this case, we didn't see any thrombus. Of course, we'll have used imaging studies like IVOS and OCT to help us to delineate what the pathology was. But we're worried that if you go with an IVO, which is a bigger catheter, we're likely, if it's a dissection, it's likely going to get worse. But with what we did with our balloon that we cut longitudinally, we're able to rescue the situation. And the patient, this was done in February, and patient it's been followed up. Presently has no chest pain and is clinically stable. Thank you for your attention.
Thank you, Dr. Damu. That was wonderful. I think it shows you need to have great experience before you enter the cath lab. Is Seko there?
Yeah.
Seko?
I'm here, sir.
I'm sure you enjoy that.
Thoroughly.
Yeah.
Okay, Prof. Danbauchi, can you continue with the Q&A section? I think we'll come to the end of the presentations. We just take us.
Yeah, I think from the panel here, I'm seeing only 2 questions.
No,
I'm right.
We have room for oral questions, panelists.
Okay.
Please, the Q&A box is not working. Thank you. So,
it's not working.
Yes.
I can see only two questions.
Ask questions. If you are on the panel, there are 33 people on the panel, you could ask questions by indicating, raise your hands.
Can I ask the...
Dr. Liko, is hands are raised. Liko, can you ask your question?
Okay, thank you, Prof. Sir. It's been a good section. It's been a great section. My question is to Dr. I think Bola Wale from UCH that presented on bullseye echo pattern, particularly in cardiac amyloidosis. I would like him to confirm to us the ejection fraction for those three patients, the ejection fraction for those three patients, and also to make a comment on apical sparing relative to ejection fractions for the three patients. Maybe we'll take it from there, sir. Thank you.
I think the person is for each person to note the questions being asked, and then we'll answer them at once. So, Prof, don't you think so?
Yeah, yes, I think so too.
Dr. Karaye's hands are up. Please raise your hands if you want to ask a question.
I raise my hand.
I cannot see Professor School's hands, but I can see Karaye.
Yeah, thank you. Can I speak?
Yes.
My hands are raised, sir.
Okay.
When it is time.
Well, it's visually. Please raise your hands on the platform. On the platform, easier to see than physically. Just click raise hands. I can see it. Okay, Karaye.
Okay, thank you very much. Mine is more of a comment on Dr. Olga's presentation. First of all, I congratulate all the speakers, and I also congratulate Dr. Olga specifically for a very innovative project, and I wish him all the best. But he seemed to have alluded that there is no chronic heart failure data, I think, around us in Africa. But I'm sure he is aware of all the big studies we are doing now, involved in the global CHF, the IVVE trial, and the inter-CHF. We all have very large data from Nigeria and all those. We've just written the manuscript on the African data of inter-CHF, and it's under review. Over 1,000 patients, many of them, about 40% from Nigeria, actually. And I'm sure there will be a lot of papers also from our own Nigerian data. So I think is a way forward for Dr. Olga's project. But I think we need to mention that we already have large data on chronic heart failure from Africa and Nigeria inclusive. So thank you.
Okay, noted. Professor Igbuchukwu.
Thank you. Good morning, colleagues. It's been an exciting morning. I also join my colleagues in congratulating all the speakers. I have a short question for Dr. Oguntade. I noticed that the QT, corrected QT was 400 plus minus 70 something. For that kind of data set, especially with the importance of ECG, I thought QTC would be part of the validation criteria, and also to explain how the patients had such a long QTs. My major comment is for Dr. Iseko. I congratulate you, especially for the presentation. The ambience and serenity of the hospital are very encouraging. I wonder how he chose those colors, you know. My two questions would be that how can he explain the very high normal coronary angio results, more than 70% in the first set of patients that they did. The acceptable proportion is about 20%. So that is my question. And then our reality is that our patients present late. I don't, and I know that the guidelines are telling us door to needle time of 90 minutes, and we cannot meet it. I think that we have to pull the bull by the horn and do our own things. Where does stunning come into this? Can we still continue to do our thing and see what we can salvage in our patients? Thank you. Those are my comments for Dr. Iseko. Thank you.
Dr. Nazir. Dr. Nazir Shehu, your hands are up.
Thank you very much, sir. Yes, thank you very much, sir, for promoting me and then for allowing me to just chip in. I just want to comment on Dr. Umar Gati Adamu. Congratulations, Umar, for this, your achievement. I didn't know you have started in the Charlotte Makeke Academic Hospital, Johannesburg. This is my alma mater. I was there. I hope you have progressed and you need to recruit more and more people to go there. I'm sure Dr. Tadezi, that I had now, he has been promoted to the level of professor, will allow you chance to bring more and more people from Nigeria to go and learn intervention there. Please, my message to you is to make sure anybody that has gone outside to mobilize others, encourage them, let them go and learn the skill very well, as we are developing at home here with various centers. When we reach a certain number, certainly the training and the procedures will be done in Nigeria solely, and we curtail the menace of medical tourism. Thank you.
Thank you. I think that there are no more hands up. Can we
maybe
take
just
the
a little
responses
comment
from
from
the
here.
various?
Okay, Victor.
Okay, Prof.
Yeah. So I wanted to comment on Dr. Seko's presentation. So the Karaoke Hospital is quite.
Yes, go on, sir.
Yes, I like the ambience of the hospital. So during the presentation, he mentioned that there was no indigenous cath lab in Nigeria in September 2019. I don't know whether I heard him correctly, but that was actually the time we had the Nigerian Cardiac Society meeting in Enugu, and we did at least 16 cases in our own cath lab. Maybe other cath labs, I think Lagos, Abuja also had their own cath lab, but I don't know whether that was what he meant by no indigenous cath lab in Nigeria in September 2019. Yeah, thank you.
Okay, we'll now take responses from the various presenters. Dr.
Okay,
Gatti,
can I respond?
I'll share your slide now so that we can.
Prof,
Okay.
can I respond so that I can concentrate?
Okay, please do, sir.
Thank you very much. I want to thank my friend, Professor Kara. Yes, at the time the write-up was made, and even now, the report has not come in medical literature. So maybe I can cite it. I know that chronic heart failure was recruited in those studies, and because they have not been published, and I'm part and parcel of those big studies. But then, if we look at, we cannot only, because when they are going to be reported, except we report our own, they will be reported as an African data, and we cannot really say African data is our own data. One of the examples is when you look at TESOS and GCHF, there are quite differences in the etiology of heart failure. And the basic difference is because of where the data were coming. In TESOS, more than 50% of the data came from Nigeria. So it will show more of Nigerian picture. In the CSF, the one you coordinated, most of the data came from Sudan. So, and we show more of the picture of Sudan. So really, yes, it's good to have an African data. It's also good to have our own indigenous data. In actual fact, we've been collecting, as I said, collecting this data gradually for some years now. And some of this project came along the line and we keyed in. And that's why you can see that we have almost 1,000 patients in chronic heart failure there. From just a single center. We have not, the other lesson there is that if we had believed only in the interstroke, which many of us participated, which I also participated as the lead person in Nigeria, the siren would not have come up. And then today, the Ibadan siren, which Kanu and other centers in Nigeria participated, is the flagship of data on indigenous data on stroke in Africa. And that is what everybody is running after the data because it's coming and initiated by individuals in those countries. Recently, we were invited to write on Nature a review article on stroke in Africa. So it doesn't mean that if we participate in those global data, we cannot initiate our own indigenous data, which we can own for ourselves and even expand it. And the main thing about this program is not just the chronic aspect, but the fact that we are going to involve the community, understand the community aspect of heart failure and the perception of our people, and then community engagement, and then the economic aspect of it, and in fact, the training aspect of it, which makes this our project unique. So I really understand that those things are there, but were not published. So I can't cite what has not been published at the time of the writing. Thank you very much.
Thank you very much, Dr. Okay. One other question for you that came from the chat box from Dr. Okumodede. Is there a plan for repeat echo evaluation? I don't know which paper he's talking about, but I'm sure you know.
Yes, we are repeating the echoes at those points. We are repeating the echoes for those who are live at the point of follow-up. We repeat all their echoes if they come. Sometimes if the patient don't come, we try several times and they don't come. What we do is, it becomes difficult to repeat the echo, but majority of the patients, when they come, and I personally, I do all the echoes for all of them.
Okay, thank you.
And we repeat their ECGs as well.
Okay. For Dr. Umar, another question came from the chat box and from the Q&A box. Please, what is agrestat?
Okay. Thank you, Scott.
No, I'm coming. I'm not through. Okay. You mentioned the verapamil in opening the lumen. What's the mechanism of action of verapamil in opening the lumen? Was nitrates given? Can you enlighten us on the drugs given as to their action? Thank you very much. That's a question. You can add it to the answer that were asked orally. Thank you.
Okay. Thank you so much, Mr. Chairman. To start with, I think I'll answer what Dr. Nazir said is just a comment, but just to answer to what he said. I'm presently presently completing my year here. I'm in the second year, almost getting to the third year, and I hope to write certificate exam by next year. Dr. Sebete now is actually, just like you said, is a professor, but he's presently HOD. Professor Manga is no more here. He's been HOD for close to 3 years now. The last time I met some people from Nigeria during the Cardiac PASCA meeting in Johannesburg, we actually discussed some few guys on how to get across to also do the training here. Of course, Johannesburg is a place where you see all sorts of things, RSCs, all the things you need, you see them. And I'm sure if you get across, he will definitely want to get you up here to train. I also did take this measurement to him. That's one. The second thing is the verapamil, just like you know, It's a cation channel blocker, and so we give it precisely as a cation. It dilates vessels, and that's all it does. Even when we go into radial, we also give it as one of our cocktail medication that we use. Aggrastat is tirofiban. It's a GP2B3 inhibitor. And of course, you know, in patients with ischemic injuries, you have a lot of platelet. In myocardial infarction, generally, platelet is what is there. And we use it, either use it as a bailout procedure, or in this kind of situation, we'll use it to just open up the vessel. Adrenaline, of course, you know what it does as well. All those medications I mentioned, or actually TNT, which is nitrosin, is also what we use as well. Okay. The other question I want to ask is whether I can ask a question. Can I ask Dr. Oga a question? Thank you so much. I realized that in all the patients he presented, it's like all his patients are alive. None of them died. That's a very nice one. That all the patients he had, the acute heart failure patient at 6 months were all alive. That must be fantastic.
No, it's not correct. It's not correct.
Okay.
Not so, sir.
Okay, sir. Okay, sir.
Hello.
Okay, sir. Hello, I'm hearing you, sir.
Yes. If you say like 8% is the follow-up. So follow-up is you are able to contact the patient or the relation. It doesn't mean that we said it's alive, and that's not what is even in the AF data. It didn't show that the people were all alive.
Okay. Okay. Thank you.
The chart I showed at the end of the last presentation is just the number of people who were contacted at 6 months. Maybe the patient or their relation, if they are late, we have the follow-up information. That's what it means. The follow-up information is available. It's not the mortality data, sir.
Okay, thank you, sir.
Is that okay?
I'm okay, sir.
Okay. Dr. Seko, are you still there?
Yes,
Dr.
I'm here,
Seko,
sir.
are you still there?
I'm here, sir.
Can you address
Yes,
the comments or questions? I thought there was a cat lab in
Hello.
I can't hear Dr. Seko.
I'm here, sir. I thought you was asking a question. I wasn't hearing you.
Okay.
So thank you very much, sir, and thank you so much for the comment from the highly esteemed colleagues and from the ACS.
The floor is still there. Okay, Seko.
Okay, sir. You asked a question. I can't quite hear you. Okay.
Seko is talking.
So I will address Professor Ajikujuku. Thank you very much, ma. I'm very grateful for your comments and all the support over the years. Our normal angio rate was about 64.3% over the period. And this is, although they are unpublished works from Kenya, one of the people we tried to recruit, an Indian, said he was not going to come because 80% of the cases he did in a Kenyan center were all normal. And that goes back to the saying of whether heart failure in Nigeria is caused by hypertensive heart disease or ischemic heart disease. The people that we did angios for, especially those that we did angios for just for heart failure, almost all turned out to have clean coronary. So that has made us to reconsider whether heart failure on its own, as to find the etiology as being ischemic heart disease, will be an indication. So, but we are still learning as we are going ahead. However, 35.6% were positive, and some of them had a positive treadmill test. Some of them had a suggestive speckle tracking on echo, and then the others came with acute MI or MI. Now, it was important to know that some patients that had very characteristic ST elevation MI likely had recanalized. The mean presentation after MI has been something around Initially, it used to be about 2-3 weeks until we did the training with NCS, the Abuja Cardiovascular Symposium, where we taught Abuja medical practitioners how to read an ECG. That has dropped the main presentation to about 3 to 5 days. So a lot of people are asking for ECGs more and able to at least identify and send at an earlier time. So that has helped. But when patients come, sometimes they are recanalized. Even with everything looking, the coronary angios come out normal. So that will affect it. The presentation by Dr. Johnson also gave also similar high normal coronary angios. So that puts into light whether we are hoping we could get some kind of way to do more studies in heart failure and determine the etiology, whether ischemic heart disease plays a major role or it is under reported. So for now, we are just doing just the cases that we think are clinically indicated.
If I have to say something, Dr. Iseko.
Yes, sir.
Yeah. If you don't have high-risk patients or patients who even have evidence of ischemia, will it be wise in poking those patients?
No, we don't do that. So
if you have a CT angio, those patients will benefit. But I hope some of those who go outside and say that the commonest cause of heart failure in Nigeria is coronary artery disease are hearing it, because sometimes it becomes difficult. You go outside, somebody is saying we are saying two different things. Some people are saying it's coronary artery disease, the commonest risk factor for heart failure in Nigeria. As others are saying hypertension. I think we should be singing one voice based on the data we have. We can't have epidemiologic transition that is different from other parts of the world. We're growing in the process. We know that if we continue to improve and imbibe bad behaviors, coronaries will be the commonest cause in the future. But whatever is helping us now, whether we are not smoking or let's stop, not even not smoke, and do other things that help us. But at least now that we have more tools, at least it shows people that we are not saying something that we don't see. At least it doesn't mean that our own myocardial infarction is different from other parts of the world where it doesn't even show their own symptoms. Thank you.
Thank you very much, sir. So we are hoping to collaborate more with the tertiary institutions around us so that we can have a more comprehensive data set by the next NCS conference, whereby we can actually look at etiology, because for patients with diabetes, long-standing diabetes, heart failure, all came out with normal coronaries, even with abnormal speckle tracking. So those are some things that we still have to see and watch how the data shows over time. With regard to the landscape that I talked about, I meant northern Nigeria. I said in northern Nigeria, as at the time of September, when we were trying to set up, looking forward to the only functional lab in northern Nigeria was a non-indigenous lab. And it was difficult to even get collaboration to ask them to help us. What did they do? What did they learn? And so even coming to Enugu was one of the learning points of deciding on how to set up a cath lab. At Enugu, that NCS that he had, that's why I said I will give a lot of appreciation to the Nigerian Cardiac Society. The programs have really helped to stimulate and bring up even the cath lab here in CardioCare. And we hope that more cath labs in this part of Nigeria will spring up, even though the profile is quite, in terms of financing, is quite low. In terms of door-to-needle time, the door-to-needle time is significantly affected by finances. We are trying to engage the National Health Insurance Scheme and other private health insurance bodies so that when patients come in, once we make a diagnosis, we get our troponin, we can go to the cath lab straight away. But that has not really materialized. We've gotten doors shut in our face. We hope that maybe with more data, we'll be able to present a more compelling case to the NHIS and to the other insurance bodies, and that may now make sure that we have a better outlook about this. But however, I'm on a technical subcommittee from the Federal Ministry of Health that is trying to institute a national ambulance system using FCT as a pilot. And so some of these things are the things we are putting into consideration. At the appropriate time, I'll reach out to the NCS so that we can get data and submit to this technical subcommittee on ambulance services, emergency services in Nigeria. Thank you very much.
Hello, can I just share my own experience here in Johannesburg with you people, please?
That would be nice.
Thank you so much. We also have this problem of patients not coming to the hospital on time here in Johannesburg as well. The guidelines we use here is the ESC guideline. And you know that you expect patients to come to the hospital. The best time you can have them with a primary PCI within first 3 hours. And if you're able to get it, fine. If you're not, of course, 90 minutes to 120 minutes is what people want. But then if you can get it within 3 hours, fine. But what we do here is that since my hospital, Charlotte, it's a referral center. We have other hospitals that feed us. If you're in CCU and you receive a call from any of these referral hospitals that they have a patient that's suspected myocardial infarction, and we know it's going to be difficult to get here within this specified period of time, we'll tell them to go ahead and thrombolize the patient. Thrombolize the patient, and then once we have a bed in CCU, we'll take you over and thrombolize. For those ones that are coming straight to our emergency ward, there and then they get a primary PCI. But primary PCI, it's not something that's feasible here for all our patients as well. I think if you can adopt that in Nigeria, that'd be a nice thing. Let them know that you can do it. They send you, they have a line that can always get across to you, and you tell them what to do, and then the patient can be referred subsequently. Of course, I've spoken to Dr. Oga in the past that if we're able to get NHS to pay for some of these services, especially coronary angiogram, it will go a long way in helping people to train and also getting people to have access to some of these things. Thank you.
Exactly.
Yes, I don't think there are any more comments.
Yes. We can.
It's time for AGMO.
Please, I asked Dr. Guntade a question. I had a question for Dr. Guntade.
Okay.
I also had one for Dr. Mugawale.
Luma.
For who? Dr. who?
Dr. Guntade, yeah.
I think okay, take your question now.
Okay. Thank you very much. Thank you very much, Prof. We actually looked at the role of the QTC prolongation in the heart failure diagnostic score. But in developing the model, only those variables that were significant in the univariate model at 5% and account for 5% of the variance in heart failure risk were included. And unfortunately, the QTC was not significant even when it was adjusted for in the multivariable model. And the beta coefficient was very minimal, it's about 0.25 or thereabouts. So it did not contribute much to the model. That was why it was not used eventually for the diagnostic score.
That's very surprising, knowing that heart failure itself will prolong it, and it is, many other papers have shown its usefulness. But thank you for your answer. Thank you.
Yes, ma'am. Thank you.
Minus 71. Those are quite prolonged.
Dr. Shibawale, he's gone. Okay. Shibawale is not there.
Okay.
Hello.
All right. Dr. Nwafo, last question or comment before we close.
Okay.
The hands are up.
Okay.
Dr. Nwafo, are you still there?
Yes. Much of what I have wanted to say have been addressed by.
Okay. I've been taken care of. Okay.
As much as we want to do procedures, we must have careful patient selection. And I had an experience where somebody came and was requesting to go do angiography, that there is a test that can be done that will show everything about the heart. As we are bringing the new technology, we should be careful as well so that our patient selection and our results will not create more problem. Thank you.
Sorry, sir. Professor, the person I was asking question on ejection fraction. Was there anything special you were interested in, sir?
Yeah, well, because he had talked about apical sparing in cardiac amyloidosis, and he painted a picture that, first of all, apical sparing is specific to cardiac amyloidosis. Well, apical sparing, however, can also be found in other causes of left ventricular hypertrophy. And besides that, if the ejection fraction for these patients were low, then the chance that there will be apical sparing for cardiac amyloidosis will be very low. That's why I wanted to know what the ejection fractions were. Did find apical sparing even at very low ejection fraction for patients with cardiac amyloidosis?
Hello, this is Dr. Ajay. The ejection fraction for both patients were low, 32, 35%. So they were actually treated also too for heart failure. And the issue about speckle tracking in cardiac amyloid, those are one of those key pertinent things that when you see it, it alerts you to what is going on. And with the ECGs that shows low voltages also. We have facilities too for bone scan, and we are still working on it to get bone scan for some of those patients because that's what the guideline recommends. Thank you.
Okay. I hope later you're going to do cardiac magnetic resonance syndrome of those patients, because magnetic resonance is found to be of help in making diagnosis of patients with cardiac amyloidosis.
Yes, but unfortunately, cardiac MRI, the machine we have cannot do cardiac MRI. It's a low Tesla, 0.4, 0.5 Tesla, unfortunately.
Okay, thank you very much. I think we can ask the president to give us something about the AGM coming up soon after this. President, are you still there?
I have to be there. Hello, Chair. Good morning, sir. Please, maybe we have 5 minutes to stretch our legs and we start our AGM, because our brethren who are going to the mosque by 1, we should be able to finish the AGM before that time. So if you agree with me, please let's go for recess for 5 minutes. Let's say 7 minutes. We'll come back 11:15. This is 11:08 by my own watch.
You know that
hello,
it's a different login setting. Login settings are on your
the
login settings are different from this one. So check the NCS WhatsApp page to get the login details.
So we are going to use, because it's our own meeting, we can't make
Having
it.
said that, I want to thank all of you for attending this last scientific session. It has been great. So we'll see you at the AGSM starting in a few minutes. Thank you very much. And God bless you all.
Thank you, sir.
Are we going to use the same link, sir, for the
Uvia is there.
No. We are using
yes.
IPP.
Sir.
You are hiding from us. Okay.
Sir, who is looking for me?
I didn't see you throughout. I was searching for you in the link.
Yeah. I'm here.
Link for AGM.
Waziri.
Strong lady.
It's only the horse that is missing now.
Strong lady. Nice to see your face.
Professor Dabachi, please show your face. So I don't know where you're hiding. Not the wise man in Babylon.
I'm being covered by somebody.
Professor Dabachi, show your face.
We are meeting the Hodo.
I'm seeing you.
I'm going to leave now.
Please, we'd like to know where exactly he's holding.
There's another link. There's another link sent to everyone.
SPS link from Professor Animation.
Okay, we'll go there. Thank you.
No,
So that we can wash our dirty linen in-house.
This is an external link now. We can't do our meeting here.
Exactly.
Make sure you don't miss your flights.
We'll
organize evacuation flights.
And maintain social distance.
Prof, I like that.
And so therefore we'll organize evacuation flights for them.
No face mask.
Please watch your flight tickets and be sure of your timing.
Professor SS, good to see you.
I have to leave now so I can catch my flight. I have to leave now.
I'm going to log all of you up.
By grace. I need to migrate immediately.
President, this is Bad Belle. He wants us to socialize. Dr. Faisal, good to see you.
Good morning, Brother.
Oga, you didn't respect your
I have a comment for you in the chat box.
Good morning, Professor Dambachi.
Dr. Oga, President.
I'm there, sir.
Nice to hear you.
Did you see my comments, please?
Yes, nice to hear you.
Yes, ma. I will buy.
Anytime you're in Abuja, we're looking forward to seeing you, sir.
You will buy what?
For all the economy. I will buy what we give to mothers when I come to Lagos.
Money, are you here or is just a photograph I'm seeing?
The first one or the second one or the third one. And somebody is writing down about Bucci
we have
as
to,
my name.
We have to be part of that.
One that is massacring my name.
Yes, ma'am.
Well, I have to leave now so I can catch my flights and great.
Bye, everyone. See you on the other side of the...
Bye.
Also, Mbakwem, you are going?
Sorry?
Yes,
are you going?
Miss a flight.
Yes, I'm leaving. I'm going to the other... I'm catching the other flight.
Correct the spelling of my name, please. Correct it. I'm not Dana. I'm not Dana. I'm not Dana Milk.
No, this is water baptism on Zoom.
Well.
Thank you very much, sir. I really appreciate it, sir. I look forward to seeing you in Abuja anytime you come, sir.
Professor Motoshe wants to greet us. Professor Motoshe is online, wants to greet us. Prof, go ahead.
Wabo, write my name properly.
I've greeted everybody. I was calling Aman to say good morning.
Prof, we missed you. I didn't see you for 2 days, though. Professor Motoshe.
I've been around.
For 3 days, I didn't see you.
No, I was there at the opening ceremony.
Okay, sir.
I was there at the opening ceremony. Then I had some other things to do pertaining to the exams and so on.
Yes.
So I'm back. At least I attended this morning session.
See you, Badasa.
Thank you very much. Solomon.
I need special flight.
See you in
Special flight from Lagos to Ibadan.
You need special flight.
Flight, yes.
Sir. I think so.
Just make your request known, and it will be granted.
Publicly.
That's right.
Where is Dr. Adanijo? Did she just switch on and went to do something else?
Yeah.
Why is she not answering?
She's in private practice, ma.
Dr. Dambauchi, I didn't spell your name like that, too. It's not
you spelled my name wrongly. You made me Dana Milk.
No, it's not me. Oh, I didn't spell your name. It's in Calabar.
Dana Bucci. Is that a milk in Port Harcourt?
No, this is not me spelling your name like that, sir. I can spell your name.
That's all right.
Mine was spelled wrongly.
But I disown this name.
Thank you, sir. I support you.
Thank you.
Professor Dambachi, we are doing water baptism for you. So change your name.
I should change my name. You should bring 10 rams, rago, for celebrating the new name.
Is this the current platform? Professor Dambauchi and Professor Bakwem, are we in the current platform?
No, I've not entered the platform for the AGM yet.
Okay. Wow, it means I'm in the wrong one again.
Hello, Prof. Hello, Prof. Dambauchi. Hello. Hello, Prof.
Prof has left. I think Prof has left.
How do I get onto the next one? I can't see any link. I've gone out there. There's no link sent to me. How do I go onto the platform
Maybe check on the chats. Maybe check on the chats.
Please, can you get back to me? Thank you.
Meeting ya through internet yanzu.
Cardiac system.